And welcome back to Pharmacology with Dr. Sokolow. So this is a quick update on the flu season and COVID-19 in 2023 because those two viral infections are evolving, and the flu season is different every year. And then with related to COVID-19, I want to give you a quick update on where we are at with vaccine and FDA-approved drugs. So in terms of the flu, so this season, the flu was predominantly caused by H3N2. You can see 73.8 H3N2 and 26.2 H1N1. There were about 18,000 deaths caused by the flu this season, and it's as of April 10th. The data were released yesterday. So the best way to protect yourself against the flu is still the vaccine. I know that this year's the vaccination coverage was not, some people still got the flu even though they were vaccinated, but it was a pretty virulent flu season. And even though some people got the flu, the symptoms were still, less than if they would not have gotten the vaccine, and probably prevented a lot of hospitalization because they were vaccinated, considering the fact that the flu was pretty virulent. And it was also actually, the flu season started early, and I'm going to show you the data here. So if you click on this link, and I have the screen, so of course it doesn't want to change. Okay, here. So this is the screen with the flu views on the CDC website, where you can see, weekly, the results, weekly. And then if you scroll down, then you have, the cumulative data over, started October 2nd, 2022. So that was week 40 of 2022 until now. We are week 13 in 2023. So you see the number of positive specimen, mainly influenza A, and then they have the breakdown between H1N1 and H3N2. So you see H3N2 is predominant compared to H1N1, and that was mainly at the beginning of the flu season. And you see that the flu season started pretty early. It started like in week 46. That's when you start seeing like a significant increase in flu cases, and that means that was still in 2022. So that was 6 weeks before the end of the year, and you see peaked like 2 weeks before the new year. So it was really like late fall, beginning of the winter, and then coming into the winter, there was a significant increase, and as of today, you see that the cases are pretty low, and now we see more H1N1 compared to H3N2 that was seen in late fall. So here you see you have the breakdown of H3N2 versus H1N1, and so now you see here still that's the number for H3N2 and H1N1 over time for this flu season 2022-2023. Now back to my slide. So CDC continued to recommend that everyone over the age of 6 months to older, especially older adults, get their annual flu vaccine. And then of course there are some prescription antiviral drug that can be used to treat flu illness, such as Tamiflu and Xofluza, so oseltamivir and baloxavir. These two drugs are covered in Module 2 of the antiviral drug. One point that is important to know is that those drugs need to be started as soon as possible. Usually it's recommended within 48 to 72 hours of the symptom onset to be effective. If they are started later than that, then they are not effective. Now let's talk about COVID pandemic. So as of yesterday, so April 10th, 2023, President Biden signed a bill terminating the national emergency over the COVID-19 pandemic. This COVID-19 was declared, if you remember, 3 years ago on March 13. And after more than 3 years now, we are officially out of the national emergency. Although the public health emergency expired, the COVID-19 pandemic remained a high priority for the CDC and the Center for Drug Evaluation and Research. CDR will remain engaged with numerous activities to protect and promote public health. So now I'm going to talk about the drugs that were approved by the FDA during, COVID pandemic, and some that receive an emergency use authorization. And it doesn't mean because the public health emergency ends, it doesn't mean that those drugs, the emergency use authorization is gonna expire. So a quick update on the vaccines. In Module 2, I talk about 2 vaccines that were approved by the FDA, and these are the Pfizer-BioNTech vaccine and the Moderna vaccine. So their first approval was for the monovalent vaccine, or the vaccine that was preventing, that was targeted a component of the original COVID-19 virus. But as you know, the virus evolved and there are a lot of variants. So now Pfizer and Moderna came up with a bivalent vaccine, which include which targets, some of the component of the original variant, but also the Omicron variant. So those 2 vaccines are approved. The monovalent and the bivalent vaccine for Pfizer and Moderna are fully approved by the FDA. And what is the difference between the 2? So the monovalent is still the one that people need to get for their primary series. So somebody who is still not vaccinated as of today would have to first get 2 doses of the monovalent vaccine. And then after 2 months, they can get a booster with the bivalent vaccine. Those who receive, their dose when the vaccine was still under emergency use authorization, probably like you did or like I did, when it first, was approved under EUA. We got our first series, and then we got our boosters of monovalent until the bivalent vaccine became available. But in order to get the bivalent vaccine, they first have to get their 2-dose primary series with the monovalent, and this is approved for individuals 5 years and older. Now, what about the Janssen COVID-19 vaccine? So the Janssen COVID-19 vaccine is still under emergency use authorization. It didn't get full approval from the FDA. Now, what about therapeutic? So as I mentioned, it's not because the public health emergency has been declared as being over that those emergency used authorization are going to expire, or that those drugs will no longer be available. So these drugs that were fully approved will still be on the market. And there are 3 drugs as of today that received the full approval from the FDA. The first one is tocilizumab, so it's a monoclonal antibody, and this one targets the IL-6 receptor. So IL-6 is a cytokine that is inflammatory, and by inhibiting the receptor, that antibody binds to the IL-6 receptor, it blocks the IL-6 inflammatory pathways, therefore reduce the inflammation in patients infected with COVID-19. This drug is indicated for patients who are hospitalized only and who are already on a systemic corticosteroid and supplemental oxygen, whether it's an invasive, non-invasive, mechanical ventilation, or ECMO. Now, the second drug is remdesivir. So remdesivir, I already covered it in my module 2 of the antiviral drug. This is a direct-acting antiviral that inhibits the viral RNA synthesis. Remdesivir is now approved for adult and pediatric patients who are hospitalized or not hospitalized and who have mild to moderate COVID-19 and are at risk for progression to severe COVID-19, which include, hospitalization and death. And the last one that has full approval by the FDA is baricitinib. This is a protein kinase inhibitor. So it's a Janus kinase inhibitor, JAK, which reduce the IL-6 pro-inflammatory response via JAK1, JAK2 inhibition. So, patients who have COVID-19, there is a lot of cytokines that are pro-inflammatory, and one of those cytokines is IL-6. And so this Janus kinase inhibitor will actually reduce the inflammation caused by IL-6. And baricitinib may also have a theoretical direct antiviral activity by interfering with the viral endocytosis and preventing the virus from entering susceptible cells. In terms of indication, this medication is indicated for adult patients who are infected with COVID-19 and who are on supplemental oxygen. So you have two drugs that are indicated for patients who are hospitalized and who are on oxygen supplement, and one drug that is indicated in outpatient and in inpatient setting, and this is remdesivir. Now you probably wonder, but what about Paxlovid? Maybe you had COVID recently, or you know somebody who had COVID and received Paxlovid. So Paxlovid, it's still under emergency use authorization, is not fully approved yet. Doesn't mean we don't use it, but he hasn't received the full approval yet. And I have a slide, my last slide, it's on Paxlovid's mechanism of action and indication. But on this slide, I'm covering all the drugs that receive an emergency use authorization, and this is something that I just reviewed today. So that's why I put as of April 11th, 2023, because this is something that may change in a month or in a year, who knows. So the first class that receive emergency use authorization by the FDA are the antiviral drug with Paxlovid, and I have a slide that I will cover after this one, and then Lagevrio. So the active ingredient is molnupiravir, and this is a nucleoside analog that inhibits the SARS-CoV-2 or COVID-19 replication, viral mutagenesis. So this is something similar to your HIV/AIDS antiviral meds, where you have, nucleotide or nucleoside analog and incorporate into either the RNA or the DNA. In this case, it's an RNA, and then you have a mutation in the viral RNA, and therefore with that mutation, it just inhibits the replication of the virus. But this drug is active against SARS-CoV-2 and not HIV/AIDS. It's not a drug that is approved for HIV/AIDS, but I just give you like an analogy for the mechanism of action of this drug. The second class of therapeutic agent against COVID-19 are the immune modulator, and so these drugs help activate, boost, or suppress the immune function just like we had some drugs that were fully approved as immune modulator. And so here there is one in the pipeline that is Kineret or anakinra. This is the active ingredient. Anakinra, it's a IL-1, interleukin-1 receptor antagonist. And so by blocking the IL-1 pathways, it just suppress the IL-1 induced inflammation, specifically in the lung, and which is useful in patients who has COVID-19. So it currently indicated for the treatment of COVID-19 patients who are hospitalized and who has pneumonia requiring supplemental oxygen, and patients who are at risk of progressing to severe respiratory failure. I didn't start this drug, but I think it's important for you to know what are the current drugs that have either fully approval or emergency use authorization in such evolving disease and field. And then the last one are the SARS-CoV-2 targeting monoclonal antibodies. So in my module, in module 2, I was talking about those monoclonal antibody, and while they were very effective at the beginning of the pandemic, because we only had at that time one strain, and they were targeting the original variant. Now they are not effective due to like the adaptation of the virus and the mutation of the virus, and now with the high frequency of those variants circulating in the US, they are not susceptible to those monoclonal antibody. And so those products are actually not currently authorized in any of the US region until further notice. So that's one thing I want you to know, is that those antibodies are no longer used because they are no longer effective. And then, so here is the slide with Paxlovid. So Paxlovid, again, haven't received the full approval, but is under emergency use authorization. And it has two ingredients, nirmatrelvir and ritonavir. So nirmatrelvir is really your antiviral medication. So it's a SARS-CoV-1 protease and pro inhibitor, and seems to be effective against SARS-CoV-2, but originally was developed against SARS-CoV-1. And so here you have that protease. You see those little scissors. So pretty much what that protease do, protease cut protein and so into like smaller fragment. So that Mpro protease cut a polyprotein into a smaller protein, smaller fragment that can be used for the viral RNA synthesis. And nirmatrelvir actually inhibit this protease, inhibit the scissors, and so the protein, the polyprotein, cannot be cut into small pieces, and therefore won't be those peptides won't be incorporated and used for the viral RNA synthesis. So that's how nirmatrelvir work. And so what about ritonavir? So ritonavir, you saw it in the HIV antiviral medication. And so ritonavir is also a potent CYP3A4 inhibitor. And this is not the first instance that ritonavir is used as a booster drug. Here it's used for its potent activity, potent CYP3A4 inhibitors. And in that sense, it allows to use less of nirmatrelvir, because what happened is like those proteases, they're also inactivated in our system, and so we have to give a high dose in order for that drug to be effective. But if you can give a drug like ritonavir to block its metabolism, you kind of boost its activity. And so that's the role of ritonavir. It's a booster. It doesn't have any activity against SARS-CoV-2 on its own. And then the indication, so as you know, Paxlovid is indicated for the treatment of COVID, of patients infected with COVID-19. It's approved for adult and pediatric patients, and with a current diagnosis of mild to moderate COVID-19 disease. It's not indicated to prevent, because the drug, act on the viral protease. So if you don't have the virus, it's not going to work. So it's not preventive, it's used for the treatment. But just like the antiviral that are used to treat the flu, this drug has to be given ASAP, and it's recommended to be to start this within 5 days of the onset, 5 days of a COVID positive result. And nirmatrelvir has to be co-administered with ritonavir, but of course, when you get your Paxlovid, all the tablets are provided, and the patient has to take 2 150 milligram tablet or nirmatrelvir with 1 100 milligram tablet of ritonavir. So all 3 tablets have to be taken together twice a day for 5 days. So this is it about my update on COVID-19 and the flu for this 2022-2023 season. So I hope you enjoyed this update, and I will also provide you some updated question on your study guide.